Cannabinoid can be also, they are pretty rarely used for that. They are used to increase the appetite. They are not so much used as nausea. Personally, I do not have much of any experience with that. The benzos we know, and the corticosteroids, prednisone and dexamethasone. In advanced cancer, we try to use a dexamethasone, which is a longer-acting drug, and therefore probably a better profile for our patients, especially when they have nausea across the board and most of the time.
Just a quick question. Does anybody know in the States where medical marijuana is allowed? It's for nausea and vomiting, right? Isn't that one of the
It is for that, yes, and it is for pain. It is also for pain. Yeah. Where's that? It keeps changing, isn't it? Because I think California?
There's 13 states that have medical marijuana.
Right. Yeah. So, but New York is not one of those. Yeah, they keep voting, and we hear that. And do you know?
Well, I know for sure California.
Yeah, I think there are many.
So it always starts in California anyway, so we don't go wrong by saying that. But I don't know. It's not in New York.
This is one of the indications.
It can be, yes, yes.
Okay.
But also the pain. And then again, some people say that smoking versus taking a pill is somewhat different. Mm-hmm. So is that the way it is absorbed, the way you use that? As you know, the smoking, there's always a component with the smoking, holding on something, the behavioral pattern of having smoking something may be very different. So I'm not sure exactly. This is something that you may want to use to look into. Why don't you look into that, Mariana, /cannabinoid for symptom? You may not look just for the nausea, but maybe also at the same time for pain. And what is really is it really proven to be all that great? If it was all that great, and if it was so good, probably it will be much more dispersed than it is. So it's like every legalization of any drug or anything that can be abused, there's always something on hold. So what hold that not all the 49 states, 50 states, I mean, will have that? I don't know.
I think that would be great to find out.
Yeah.
States have
yeah.
15. Yeah, it's increasing. It's
15.
Not increasing. Yeah.
No. It is increasing, of course, like most of the thing. But is that really all that great? And sometimes things, will get to the market without having made really their proof. It's like, remember when we wanted to push the heroin for treatment of pain, and we finally, we look at all the literature on that and finally ended up that it was not all that great, sufficient enough to have a risk-benefit and say, well, everybody should have that. No, it was not all that great when you look at benefit.
Alaska, California, Colorado, Hawaii, Maine, Michigan, Montana, Nevada, New Mexico, Oregon, Rhode Island, Vermont, and Washington.
That's really interesting.
Okay.
Many of those states are very conservative.
Absolutely, like Maine.
So it just didn't pass. There was discussion in these states. So it would be great to see the literature.
Yeah, see the literature, and is it really something that we should consider and encourage our patient to do?
I think the side effect profile too is the side effects are worse if the patient has not used marijuana in the past.
In the past.
Like you just start them on it for symptom relief of something or for an appetite stimulant.
Right.
The side effects sometimes become tolerable if they're not.
I see. If they are not used to the drug prior to. Well, that's something that we look into. That may be. Hey, that may be part of your next journal club or something. Okay, good. Constipation. Well, we don't like to talk about constipation. This is not high on our, isn't it, on our radar list. But, you have to be constipated one in your life to say that it makes your life miserable. And patients are really struggling with that. And of course, the sicker you are, the least you eat and things like that. And it's really more frequent, as we saw. The prevalence is there, and it's quite annoying. And there's a lot of recipe on the market. Again, this is something that we need to question a little bit further before knowing which drug will be the best for your patient. So about 20 to 50% of your cancer patient, again, depends on the type of cancer that you do have, probably common in all population with advanced illness. Population also that it's not mentioned here, but the elderly, the aged population, it's very, very frequent, demented people, and everybody that's had a debilitated illness, it's fairly common. Again, etiology can be due to many things, and again, if we investigate that and we have a sense of what is deficient, what is missing, we can correct it effectively and not just throw laxative for the sake of laxative. Sometimes it's not laxative that you need, it's something else. So diet is always good to investigate. Easy eating, not eating. In advanced disease, as you know, the diet is insufficient to maintain a good bowel regimen because they don't eat so much. They are nauseated, they are too weak, so on and so forth. Loss of appetite. Dehydration is a very common also cause. They don't drink, we don't eat enough, and inactivity, it's another that's very hard to correct because most of the time when patients become inactive, it's the last month of life, Karnofsky below 20, they are in bed and it's hard to correct. So this is something that you have to live with. Advanced age, also there's change in the GI tract and therefore there's a change in the bowel movement as well. And some lesion, of course, compression from the inside, from the outside of the gut that can give you constipation. You can have also a lot of diseases that are, nothing to do with your cancer or nothing to do with the disease that you are trying to deal with. Can be endocrine dysfunction. We have a lot of patients who are diabetes or hypothyroid and have a cancer, happen to have a cancer. So make sure that their hypothyroidism is okay. We are not dealing with something that's off balance. Electrolyte imbalance always there, hyper, most of them can cause you some of GI disturbances and all kind of GI disease per se. Diverticular disease, colitis, stenosis, hemorrhoids, pain in that area that will prevent having bowel movement. So drug related, there's many agents that are really here causing constipation. Opioid is one of them, probably the most common. Some diuretics, anticholinergic drugs. It's good to put a scope patch, but don't forget that you may have some side effects according to that. Iron, I've seen patient coming on iron, and first of all, iron on a dose that's not really adequate. Iron, in advanced disease, trying to correct that anemia by iron is not really all that great. You are not probably being able to correct that. The absorption may not be the best. So patients on iron is very, very constipating agent. So think about that if it is useful to keep that on. Some chemotherapy and so many other agents that can give you constipation. So what's happening, there's two things that will happen when you give constipation. There's one that has to do with the motility, the intestinal motility, and the other one will have to do with the balance of fluid and electrolyte balance. So if we can have a little sense of that, we can, of course, correct in a better way. So the motility facilitates the enzymatic bacterial breakdown of food. It's necessary. If your gut is totally paralyzed either by agent or by something like that, of course, everything will become harder and won't move along. Therefore, you will become constipated. It's under the mesenteric nervous plexus and the parasympathetic system. So if you have diseases, and it's a fairly common example in ALS patient who may have mesenteric nerve plexus disturbances, or it can be multiple myeloma. Those patients have a tendency to be very, very constipated because of that. And there are many neurotransmitters also that are involved. Therefore, the motility is altered in many ways. Fluid and electrolyte balance. So the fluid comes from the diet, but also from the secretions of the gut. Do you know how many liters we secrete through our gut from the mouth to all along the gut? About 7 liters a day. So when people are saying, I'm not eating, I'm not drinking, therefore there's no product there, there's nothing to come out, well, that's not true. Because there's at least 6 to 7 liters of fluid from saliva, from gastric juice, from this and that are there and that are playing a role in digestive the food or whatever there is into your gut. So we know that the absorption of all the nutrients are really in the small intestine, and the absorption will depend. There's a lot of electrolyte transport through the membrane of the gut. So again, if you have an imbalance there, you will have problem. So treatment depends on the assessment. There's no treatment without a good assessment because we need to know what to correct. So diet, fluid intake, first question, bowel habit. You know that some patients, they will go once a week and that's it. They always have done that this way. So it's good sometimes to ask the question, well, is that okay for you to do this way or it is not? No, I used to go that many times and now this is it. Don't forget that physical and social impediment can also cause constipation. Imagine yourself being in a hospital in a 2 bedrooms and you don't like the patient next door, or the door to go to the bathroom is not conducive to anything. There's a lot of noise. I don't know. A lot of things can. So it's not surprising that patients being hospitalized can be more constipation than if they were at home.